not a very emotional guy. My wife says I have no emotions. I say that she has too many. But it's very weird coming back here. I'm feeling a lot of emotions. It's very strange and sad to me that I don't know all of you. Like you, I know. And Beta was in here earlier. I can't believe that guy's still a resident. But I feel in this room a little sad. I don't know any of you. But a very, very profound desire to help you in any way I can, in a pay it forward kind of way, because of the sacrifices these faculty in the back and Jimmy Willis made for me in my time. I hope you guys have as good an experience as I did. And when I say good experience, I don't mean only good things happen to you. I mean that you support each other and you are supported by others, and you learn how to be a great ER doctor in one of the most incredible environments I could hope for. This place is great. And a lot of people put in a lot of time to make me competent at emergency medicine and teaching. So thank you all for coming and braving COVID. If any of you are like me, I can't wait to go back to not washing my hands. All right. It's just gonna run through, huh? So who here has seen a patient with syncope in the ER? Who here was like, dude, I got this. I've read some papers. I just talked to Jimmy Willis about it. I'm gonna present to this other attending. I'm gonna nail it. And then that other attending is like, that's a stupid plan. I don't know why you would say that. We're gonna do this. And you feel defeated. Anyone? Anyone? Yeah. I don't like that. I like having a very deep, evidence-based understanding of the decisions that I and we make. And I had a week when I did this lecture where I had 3 syncope patients. And when do you get feedback on your syncope patients? So when you're an attending and you're not presenting. So it's when you admit them, when you sign them out, or when they bounce back. And I had all 3 of those in 1 week. And in all 3 of those, when I was talking to people about the cases, I was like, you care about that? Like, that's not a thing. And then I'd be like, but what about this? And they're like, no, I never worried about that in my life. And I'm like, how can everyone have such divergent views on syncope? So I ignored my wife and children and did a very deep dive into the syncope literature. And I came up with this lecture and this framework that I hope is really helpful to you. So for starters, it's going to do that every time, huh? This is why everyone does something different with syncope. There's actually been 2 clinical decision rules to come out since this that I'm going to discuss. But this is a view of the syncope clinical decision rules that have failed external validation. But since we have no syncope rule that is externally validated, people seem to refer to these a lot. And if you look, a lot of similar things come up. Abnormal EKG, which it always bugs me that you have to go to like Appendix B and like a separate downloadable journal, whatever, to get what they classify as a normal EKG. And some of them are like super weird. Like anything that's like not completely normal, which it bothers me to no end. Age seems to come up a lot. Prodrome comes up some of the time. And all of these suck. And I'm going to get into why these suck. And I'm going to break it down for you in 3 easy steps. Dude, it's doing that every time. All right. So, all right. I'll just go really fast. No, that's the computer. So step 1, I'm going to try to just ignore the animation for now. So step 1 is it syncope or is it something else dangerous? Okay? Things that come up most commonly are seizure, mechanical fall, although I feel like in the world of medicine there's more in heaven and earth than in our philosophy, and it could be something else totally different. So how do you tell the difference between these? Who's got a guess? There's a lot of money. I love it. So post-ictal is a big one. The confounder for that is if someone is post-concussive, they can also be very confused. But that is a great one. If you're going to talk about syncope or seizure, typically post-ictal is excellent and evidence-based. What else? You are half 100% correct. So tongue biting, 100%, especially lateral tongue biting. And they actually have looked at lateral and bilateral, and obviously bilateral is more consistent with seizure. So if they're post-ictal or they have lateral tongue biting, it's very, very, very likely seizure, right? With the urinary incontinence, I feel funny because they teach illness scripts in medical school and in the textbook. And an illness script is like how disease X typically presents. And that's really important to know for a lot of really important things. The problem is applying it in a like rule out emergency medicine scenario can sometimes be fraught with difficulty. Because what happens if someone has they go into refib, they lose their postural tone. Very common for them to have urinary fecal incontinence. So it makes it really hard to use that as a like rule in or rule out criteria. What are some of the things that you've been told help differentiate these?
You look at injury pattern, like mechanical falls versus they might try to protect themselves and have other injuries as opposed to Syncope where they often just want the bottom of their face or head.
It's funny you bring that up. I have not seen specific studies on pattern of injury. I've seen studies that evaluate facial trauma, and Sinner actually goes by that rule, or I don't know if he still does, but I had cases with him where he goes by that rule, where if you faint and you have facial trauma, you get admitted because it was so sudden you can't protect yourself. But he uses that as like a risk stratification tool and not as much a mechanism. But you know, if someone has a prodrome that they may or may not remember, they may slowly go down, and then how do you tell? Witness, not witness. You bring up an awesome point. Who here has had a patient where the family reports, yeah, that was a mouthful. Who has had a family report a patient was shaking, and then it turns out it was a myoclonic jerk? Right? Terrifying. And I have trouble figuring that out, and I feel very goofy when I do this, so I'm sorry. My trick is I ask the family to imitate what they look like. And sometimes they'll be like, he has a seizure disorder, it's a generalized tonic-clonic seizure. I don't like make them do it. But it is really interesting because I've definitely had a few cases where like, oh yeah, he fell over, he shook with a seizure, everyone said it's a seizure, and usually they're very emotional because their family member, that's terrifying, and you're like, well, what did they do? And they're like, that is not a seizure. I mean, it might, but that much more consistent with a myoclonic jerk. All right? So my method, as you guys may have seen the slides, but for postdictal confusion or lateral tongue biting are the two that I really care about for syncope. For a mechanical fall, it's really tough. It more or less depends on do they remember it. And if you fall and you hit your head and you have a concussion, you might not remember it. Who here has seen this like nursing home patient, bruise on face, rule out head trauma? And then I love they always write in altered mental status, and then the history is like dementia, ANO times 1, and then you call and you're like, is this patient ambulatory? What is it? And they're like, oh, I don't know, that nurse went home 5 minutes ago. So your job in emergency medicine, our job in emergency medicine is rule out everything life-threatening and dangerous. If you don't know what it is, I personally don't feel comfortable guessing unless I have specific reasons to clinically rule them out. So then you have to treat them for all of them, okay? I'm not going to get into the workup for mechanical fall and seizure as much. That'll be a topic for another day. But if you can't clinically rule it out, you need to test for it. Question? No. Okay. So that's step one, syncope versus seizure versus fall versus other. So that's a pretty easy step, right? We can all do that? Yeah? The next step is, in my opinion, the reason why all these clinical decision rules fail. Who here has heard the phrase true syncope? A couple people. You want to throw out a definition? No. So true syncope can be differentiated from symptom syncope. You guys are all emergency medicine doctors, right? Syncope is defined as a loss of postural tone followed by a complete resolution of symptoms. Symptom syncope is I have belly pain and I fainted. What's the diagnosis? Belly pain and syncope. Three things. AAA. Ooh, who said ectopic? Gold star. So yeah, AAA is the classic one, but obviously you're in female ectopic until proven otherwise. That's, oh, did it run through everything? Chest, who's in the back? Chest pain plus syncope. So classically is dissection. Can be ECS, consider cancer, swollen leg, tachycardia, right? Syncope. That's a PE. You're going to write syncope on that chart to like up the billing or whatever, or to identify high risk feature. But you're not admitting that person for syncope. You're admitting it for something else bad. True syncope is no symptoms, usual state of health, feeling fine. Plus or minus a prodrome, loss of postural tone, and loss of consciousness. Return to an asymptomatic baseline. Okay? One of the reasons why all those clinical decisions failed is they said what? We're going to have everyone with syncope entered in this study. And we're going to look at all their characteristics and figure it out. You can syncopize from a dysrhythmia, from a benign cause, or from anything in the emergency medicine textbook that can kill you or cause you to be sick. A clinical decision rule is not going to identify all of those, and that's why they all fail. Okay? So that's your second thing. And the question is, how do you differentiate them? I have good news for you. The AHA is on your side. They do a detailed history and physical exam. Strength of evidence, recommendation 1, highest. Do a history and physical exam on a patient. But the level of evidence is only a B, which is always amusing to me. But this is what you do when you see a syncope patient. Okay, I've identified that it's syncope. I want to ask a extremely thorough review of systems to make sure I'm not missing a dangerous thing that can cause someone to faint. And that's step 2. That's pretty easy, right? Who here heard a rumor that everyone admitted for syncope had a PE? Anyone hear that? Was it an Italian study? No? No one? So did you guys admit someone for syncope and get asked by the internal medicine or whoever you're admitting to about a PE workup? I did. Did any of you guys read the paper? Okay. So first of all, they just chose everyone that fainted. They had like a 10% rate of tachycardia. They had like an 11% rate of hypoxia. They had in the teens with like active cancer. So I think a lot of people have identified one problem in the paper in that everyone got a D-dimer or a CTPA, which is a known recipe for overdiagnosing PE. But the other thing that study did was they included people with cancer, swollen legs, tachycardia that came in with syncope. They didn't syncope. They're not being admitted for syncope. They're being admitted for PE. That's a silly thing. And there's been numerous ED studies that have re-demonstrated a very low rate of PE in admitted patients with syncope. It's 1 to 2%. Which, if you look at PERC, for example, if you're low risk and you use PERC and you quote unquote rule out a PE, your risk is less than 2%. Okay? So this is the way some of these studies are done that are a little bit baffling to me and I think disingenuous when it comes to our evaluation of syncope in the ED. So step 3, you've now identified someone with true syncope, and your next job is to figure out the risk of a dysrhythmia or an arrhythmia. Okay? I know you guys just saw one. What are some features that you guys think increases someone's risk of having a dysrhythmia? Previous history of arrhythmia? Yeah. History of heart failure is excellent. That's in every single study. What else? Age. Oh, age is a great one. Who said that? Yeah, we're going to get to that. What else? All right, time out. Can I just, first of all, I will say I have an undying love for Ian D'Souza, one of my favorites. I gave this lecture at AAM, and they recorded it, and they like put it on their website. And every month they have a featured lecture. And this was my featured lecture emailed out 2 days ago. Within, how long after the email?
I just saw your face on the hey, Grock to give lectures. Listen to it like this is nonsense.
Well, I haven't emailed them back yet because I'm quite busy. But my reaction is like phone buzzes, like, oh, that's awesome. My picture's on an email to like a ton of people with this lecture. I like, that's really cool. Buzz. Grock, these are some good references for your talk that you didn't talk about. Like, paper. I was like, yes, that's why I love you. So yeah, we got a few. What else? Yeah, normal EKG. That's an easy one. So the problem with this for me is there's conflicting data. Some papers say one thing's important, another paper says it's not important. And I had a very hard time parsing through and figuring out what really are the key features that would, I call it like the yellow flag in football, like throw the towel and throw the flag in, game over, admit, do not do anything else. This is a list that I came up with that I think are good. If I have a patient with syncope that has any of these, in my mind, it's an automatic admit or at least a shared decision making. So family history of death at a young age or sudden cardiac death. How many of those syncope clinical decision rules included a family history of sudden cardiac death? 0. If you're going to take a population of syncope patients and look at who dies and who doesn't, how many patients have a family history of sudden cardiac death? Is that really going to reach clinical significance, statistical significance, right? So this is one of my rules that is not in any of the clinical decision rules. Next is age. I adore this one. Who here has been told, oh, he's over 65, you got to admit? Yeah, so that's a thing from failed, not externally validated clinical decision rules, but we don't have anything good, so a lot of people rely on that. And when I did a deep dive in the literature, I was really surprised. There's one paper that says, that specifically looks at age and says it's not statistically significant unless you're over 90. So they say if you're 89, you don't have an increased risk of death from syncope, but if you're 90, maybe admit. And I can't help, we said some more from the room, I feel like I have to talk about this case because I feel like you would do the same. I saw an 85-year-old man, good old Kings County. Have you guys heard the legend of Dennehy? So this is Dennehy. And he was fasting for morning labs. He was standing in a long line to wait for those labs when he had a syncopal event. And I'm like, 89 syncope. I'm done looking at this chart and thinking. I did my history while I did the line of labs while I did the history. I went and sat down to order the labs. And then he looked at me, and I'll cut out his curse words, but he said, hey, what are you doing? And I said, 89-year-old syncope, I'm going to send off the labs, we're going to admit him. And then he says, you put those, I'll cut out the threats of violence. But he very gently said, you put those labs down right now. And I said, what? He's 89 with syncope. And he said, what are you scared of? I said, well, I'm scared he's going to die. He said, yeah, that's what 85-year-olds do. How many days does he have left? You want him dying in the hospital with some intern putting a needle in his groin? Or you want him dying at home comfortable surrounded by his loved ones? And I just stared at him and I was like, this is crazy. He's over 65. And he said, you put down those labs, they're more threats of violence. And we sent him home. And so I actually made up, there's some studies that have like a graph, like a linear graph with like admit versus discharge. And it's like low, 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 goes up at about 50, 60, and then at 65, the admit rate shoots up. I kind of wanted to make it the Dennehy rule that when you're like 90, you need to start discharging these people because they're going to go home and die. And it's actually made me very conscious from a pal care perspective of what is the real risk and what does this person want to do, right? Patient perception of risk is very different than ours, so I find shared decision making a very nice way of informing patients of what their outcome might be. ASAP came out with a clinical decision rule for syncope, I want to say 2007, it might have been 2009, and they have a very eloquent sentence that says something like, age is a continuous variable and therefore reflects the advancing age of the heart. The older you are, the higher your risk for an arrhythmia, but there is no specific age cutoff that confers an elevated risk. If you're 70 and you run 5 miles a day and you're a vegetarian, your heart is better than mine. If you're 50 with diabetes, hypertension, end-stage renal disease, regular cocaine and meth use, your heart probably isn't great. So age is an extremely tricky one that as a resident, you need to just, I guess, do what your attending says, but when you're out and you're a grown-up, you don't have to consider as strongly as you might think. Next is a history of heart disease. So MI, CHF, and structural heart disease. And the reason why is you assume that the heart is stretched out, the heart is misformed, and that can mess with the conduction. So it puts them at a higher risk for an arrhythmia. Any exertional syncope, I admit. That's actually not on a lot of the clinical decision rules, but a lot of other papers have said that's associated with badness, and it makes sense to me. Any hypotension, that one bothers me because I always feel like if you vagal, you're going to be hypotensive. But a lot of these studies are like syncope in the field, and when they get to the ER, they're hypotensive. Or when EMS arrives 10 minutes later, they're hypotensive. So any hypotension plus syncope, I admit, and then there's abnormal EKG. I know you guys did an EKG today. Is there any chance we'll do another EKG? All right. So I want you to, this is, I was going to buy a QuickBook, and then I went on these meetings for Ford at Hilton, and they had like thousands of these pads. So I guess I should put that in my place of interest as like sponsored by Hilton. So everyone take one sheet and pass it down, and then we should have extra that should go out, but I can always know. Yes. I do. As like a risk factor for badness, yes. And I have more. I wasn't sure how many of you there would be, and to be honest, if anyone wants, bring them up. Oh, you got it. Do people need them? Because they just need to be numbered. And I only numbered like 48. So there should be a number in the top corner. Does anyone have one with that number?
Yeah, I don't have it.
That's fine. So you can be, we're going to go opposite, but you be 100, 99, 98, 97, 96, 95, 94, 93, 92, 91. All right? And then I have taught this a few times, and I'm very confused when people screw this up, because you guys are all adult doctors. And I've chatted about how to make this less confusing. So we're going to do it. We're going to fold it hot dog style. You guys know what hot dog style is? I did it once, and I was like, fold it like this. And they're like, what? And I like saw people doing it wrong, and then someone goes, hot dog style. And I was like, oh. Okay? And then I want you to fold it back. Hot dog style. And then I want you to tear it down the middle. Doesn't have to be perfect. So now you have 2 sheets of paper. One of them should have a number at the top. One of them doesn't. The one that doesn't have a number on the top, you should write down at the top your name and answer key. I have I got a handful of built-in pens. Anyone needs a pen? Should I just throw it? Like I said, conflict of interest. Okay, so if we're on the same page, you now have a sheet of paper that says answer key in your name, and you have a sheet of paper with a number. Everyone with me? The one with your name that says answer key, you're going to keep that. All right? The other one, you are going to draw a picture. You do it sideways, it probably makes more sense, of an EKG. Typically, I do that would require admission. But if you guys want to be tricky, you can just draw any EKG, and then you decide admit or discharge based on that. It can be any EKG you want. As long as you know in your head that you're trying to draw.
You want a 12 lead?
Just a rhythm stress, but if you want to EKG, it would take some skill to do it. Okay? When you're done with that, on your answer key, you're going to put down the number of yours, and then you're going to write down what it's supposed to be. That make sense? I'm taking a really long time because this is like not on multiple times, and I'm like, we're going to do this right. All right, let's say 30 seconds to do that. All right, so has everyone drawn a picture and written down what their finding is on their answer? Is everyone ready to go? So what we're going to do now is everyone has their answer key. You hold on to your answer key, it's got your name on it. You're going to pass the picture of the EKG around. And when you get that EKG, you're going to write down the number, and then you're going to write down the finding. Okay? If you want, you can do the name of the EKG, or you can do, if you want to make it like a word review, you can do like the specific phrase to describe it. All right? And you're going to get, how long with each one? Are you get 10 seconds? You're going to get 10 seconds of each EKG, and then we're going to pass it. I'm starting to stop. You guys all ready? Oh yeah, which way? Everyone pass it to your right, and then when you're at the end, pass it up. 20 seconds? All right, we need 20 seconds to the EKG. All right, ready, set, go. person I did this with, I like they're adults that are and I like explained it, and then I was like, bro, and we're just saying it. Went off the internet. They look like all right, switch. Everyone switch. Pass it down. Yeah, you might want to sit closer in this one. Get your steps up. I guess. Yeah, I think it's falling apart to go to. Oh yeah, here, I'll stand in the back. I have more. All right. All right, you guys ready to switch today? What's up? There you go. All right, you guys ready to pass again? And then, guys, if you want, the back are like doing it together, so they're hugging. All right. Let's make this a free fall. As soon as you're done, pass it, and let's see how fast you can go.
37, are we dropping any keys? 37.
I want your feedback on this. If this is,
You want general feedback? Or just some feedback?
really, like in general, if this is a good game.
Okay.
I think it's a fun idea. You want to start to think about it. It doesn't work as well as
Setting it up.
I can hit my steps. And then I've had different ways of doing this. I think in the interest of time, maybe I'll skip going over what each of these are. But what I can do is I'll leave these up here, and Ian D'Souza was like, don't worry about it, Rob. I'll leave each other individually, go over this, and what these are. Give them all hugs after a couple right there. So, no. The other thing I've done, if anyone, who's writing the blog these days? So the other thing I've done is I'll take these home and take pictures of them and send them out. And then everyone, or like on a Google Doc, and then people write in what they meant it to be. So there's different ways of distributing this. I'm happy to do whatever you guys want, or leave them with your chief, put them on the blog, whatever you guys need. But I hope was that fun? Did you guys get it? Was that engaging? All right. Some movement. Yeah, you always have artifact. So when I think about what makes me admit someone for syncope, this is my list, and I break it up into 4 categories: non-sinus, intervals, ischemia, and syndrome. And every EKG I look at on someone with syncope, I think about these 4 things. So I can just quiz you. Did anyone see a non-sinus EKG when it was passed around? So what did you guys see? Yeah, VTAC, AFib, torsades, flutter. Okay. People oftentimes will group 2nd and 3rd degree AV blocks into non-sinus rhythm. Did anyone see any 2nd and 3rd degree blocks? Yeah. So one thing I will say that bugs me, a lot of those clinical decision rules, when they say abnormal EKG, they included 1st degree AV blocks. I personally don't consider a 1st degree AV block like a throw in the towel, admit for EKG abnormality, but I find it very strange that that's how they were classified in the papers. But any 2nd and 3rd degree blocks, obviously, they require admission. Type 2 secondary, 3rd degree needs pacer pads and likely CCU. What about intervals? Anyone see interval problems? Yeah. Short PR, WPW, that can go to syndromes too. What else? Long QT, long QRS. Okay, evidence of ischemia, you guys all know that. And then specific syndromes. So WPW got mentioned. What other syndromes do you worry about? Regatta, what else? Yeah, Wellens, what else? Ooh, I heard it somewhere. Hypertrophic cardiomyopathy, and there's a new one. I think, yeah, arrhythmogenic right ventricular dysplasia. I haven't seen a case yet. I may have missed 1 or 2 or 3. But that's my list. And then keep in mind, I personally think if you have an anterior fascicular block or posterior fascicular block, that to me is enough to typically admit. Who here has seen a trifascicular block or knows what that is? Do you guys remember sure about me being a dumb resident? So I saw a guy with syncope, and I don't remember the attendings, which bothers me to no ends. I'm worried one of them is you, and you're going to call me out. But I think I was like a end of 1st year or early 2nd year, and I got a guy with syncope in his EKG. I was like, that looks weird. So I drew all his labs. I sent them off. I presented the attending. I'm like, yeah, this guy, syncope, labs are off. This is his EKG. It's weird. We're going to admit him. And the attending looks at it and is like, oh, it's a trifascicular block. Get the pads on him. Make sure he goes to CCU. And I was like, cool. And then I was like, do I tell this attending that I've like never heard of a trifascicular block or just look it up later? So I like looked it up and I read all about it and I was like, okay, trifascicular block, pacer pad, CCU, we're good. So like 6 months later, we get a guy who is tachycardic to 115 who had a trip and fall and ankle pain. And his EKG was a trifascicular block. And I was like, I'm a goddamn superstar. I nailed this. Send off all the labs. I x-rayed his ankle, which was negative. And I called the cards fellow. I'm like, so we're meeting me and this guy, do you put the pads on? There's kind of a pause, and the fellow was like, did you have any symptoms? I was like, what do you mean, like, symptoms? He's like, no, like, was it syncope or fall? I'm like, no, it was fall. And he's like, so you didn't have any symptoms? I'm like, no. And there's, like, kind of a pause. And he's like, I don't think we, like, admit this. And I was like, come on, dude. These guys can go into complete heart block. I just read about this. High-risk case, this guy's being admitted to your service. And he's like, okay. And then I'm like, dude, this attending is going to think I am amazing. And I'm like, so that ankle sprain? Picked up trifascicular block. Got the pads on, we're admitting him. And the attending says, oh, do you have any symptoms? And I'm like, why would you ask you about that? Apparently in my meeting, I missed that some trifascicular blocks don't necessarily degenerate into a complete heart block. And this is like EP level stuff. But your out is if someone syncopizes and they have a trifascicular heart block, you assume that that trifascicular heart block degenerated into a complete heart block and caused the syncope. So they get an automatic AICD. If you find an asymptomatic trifascicular heart block, that can actually just go to cards follow-up, and they get scheduled for an EP study. And when I read about this, I didn't understand it. I don't know if anyone can explain it better than me, but it has to do with where in or around the AV node the first degree heart block is, which as an ER doc, I don't know how you're supposed to figure out, but apparently there's an EP study for it. A trifascicular heart block is a first degree AV block, a right bundle branch block, and then either a left anterior or left posterior fascicular block. Okay? Do you guys know what left anterior, left posterior are? Do you want me to like review it real quick since I have what I hope is a clever way of remembering it. Okay. So, should I go old school? There's no try. If you guys go to Life in the Fast Lane or just Google it, it'll probably come up pretty good. But who here knows their alphabet? Who here knows their numbers? Yeah. So for left anterior and left posterior block, we're going to do this. What comes first in the alphabet? Anterior, posterior? Anterior. What comes first numerically and alphabetically? 1 or 2? 1. So left anterior vesical block in lead 1. What comes first in the alphabet? Q, R, or S? Q. Left anterior block, lead 1. You have a QR complex. What comes first in the alphabet? Left or right? Left. There's a fun pause there. In a left anterior vesicular block, in lead 1, you have a QR, so a little dip and a big R, with a left axis deviation. That's what I remember. Everything else is the opposite. Okay? So in a left anterior vesicular block, what comes second, 1 or 2? 2. In lead 2, you're going to see a RS. Okay? And 1 and 2 are your identifiers for lateral leads and inferior leads. So you're supposed to see that in all the lateral leads and all the inferior leads. Okay? A left posterior vesicular block is the opposite as well, in a little bit of a confusing way. So I don't want to fall off the rails here. I just remember left anterior vesicular block, QR in lead 1, and its left axis. For a posterior vesicular block, it's the opposite. Sound good? All right.
And does the chronicity of those factor in? Like if it's on an old EKG, does that still factor in terms of disposition?
So that's a great question. I've heard that asked actually a lot for QRS, like wide QRS, old and new plus syncope. And for me, it's still an automatic admit. And it's similar for left anterior and left posterior for me. I couldn't find specific papers that looked at just those, but they're always classified as abnormal EKGs, and it makes sense to me that those would predispose someone for an arrhythmia. Okay? WW, Hokum, ARVD, Brugada, and then this is my list. You guys are all adults. I don't want to run through a million EKGs and bore you guys to death, so I want you guys to look these up on your own if you don't know them. Except for trivesicular block, because you guys all know them.
Same question for us teaching.
Yeah. So if you come in with an old T-wave inversion, I don't count that as a must admit. If you have a new T-wave inversion, or God forbid, 2 EKGs in the ER that are different, then I'm done. Yeah. Thank you for the clarification. All right. Now there's 2 other studies that have come out since I made this lecture. One is this, the Canadian syncope score. They named everything Canada or Ottawa. And they did something that I really enjoyed, in that they took adults with syncope and not seizure or fall that had a negative ED workup, which is sort of my framework for identifying true syncope patients. So they actually identified a population that we care about. And they did all sorts of fancy statistics, and they came up with this list, and everything got a point total. And this is impossible for me to memorize because some of these are worth 2 points and some are worth 1 point. So I've actually never even attempted to memorize this. I just pull it up every time. And there's a point system that correlates really, really well to short-term risk. I hear they're in the process of externally validating the study. We don't have it yet. So this is not ready for prime time. If I'm on the fence about what to do with someone, sometimes I will do this and use this in my shared decision making. If I think someone should go home and I want to double check, I think that's fine. But I wouldn't use this as a 100% rule right now. The other thing that I struggle with this is if someone has a QTC at 550, but they had a vasovagal history in their story, maybe I'm just conservative, I would still admit that. But on this study, it's kind of interesting because you could have an abnormal QRS and still be discharged by their point scale, which bothers me. The other thing that comes up is this troponin. And that was something I really wanted clarification on in my evidence search, and I found nothing useful. So ACIP clinical policy says very clearly there's no specific history or physical exam features that would make you want to send labs or not want to send labs on someone. They say that's entirely up to you. You can send labs on older people with syncope to make sure it's true syncope and not symptom syncope, right? God forbid they're like sodium is 115 or their hemoglobin is 4 because even though you did a good history, you missed the fact that they're chronically severely anemic. And the troponin is tricky. Studies that look at troponin and syncope say that if a troponin is sent and it's positive, they're high risk. But we don't know who to send it on and for what reasons. My own practice, that's not evidence-based because there's no good evidence, is that I will send a troponin on anyone over 45 with syncope. There's old data that says if you're less than 45, your risk of death from syncope is low. And people under 45 much, much less commonly have like ACS, problems with their heart, history of their mind. So I send it at 45. It is completely not evidence-based. You can practice however you want. I do want to point out that I document very clearly that syncope is sent as a syncope prognostic feature, and that I do not think that this is ACS, and I'm not sending like a 0 and 3 hour trope. I'm not like looking at a heart score for these folk. I'm just doing the troponin to tell me if they're high risk syncope. That makes sense? Are you guys getting tropes on your syncope patients?
No.
Yes.
In practice, yes, they are people, but nothing they have about.
Yeah. I think the other hard thing is if someone is like 70 with like CKD, you know if you send a trope, it's going to be positive, and then you're going to be stuck admitting them. So that might be a patient that you don't send it on if you think you might want to send them home.
If you want to clog your emergency department with patients, you should send troponin. You don't need to be the patient.
That is one side of it. So the newest thing that came out, this was actually published in February 2020, so I added these slides pretty recently, but it's called the FANK score. They did something sort of similar, except they had older than 60, and all of them got an EKG, and all of them got labs. And they did something kind of weird, where they were like, oh, we found this person with syncope, like research person runs over, draws labs, and then sends them to a secret lab. And then the attendant comes over and does whatever the attendant wants, and is not informed of those results, which is kind of weird. They all got, apparently, a high sensitivity troponin, and they all got a fancy version of a new version of a BNP, which bothered me because I don't like BNP as a test, and I do not send it on my syncope patients. It's one of the San Francisco syncope rules. I'm sorry, it's one of the chess rules that failed, and San Francisco syncope is history of CHF, but I don't typically send it, but this was sent. And they looked at 30-day death or like bad cardiac outcome, which is interesting because I don't know why we all look at 30-day risk factors when someone comes to the ER. Some people are going to die in the next 30 days. It may or may not be related to that index visit. And I kind of want all of our research paradigm to shift to shorter-term outcomes. At least look. Give me a 2-week and give me a month, right? Like the heart score, I love it. It's great. It lets us discharge some people from the ED. It's very evidence-based. Do they really care if someone's risk of a heart attack in the next 30 days is 15%? They can see their PMD in a week. What are they going to be doing in the hospital? Sorry?
Not going to see their PMD in a week.
Exactly. Well, I am lucky enough to work at the VA, where I can message their PMD, and their it's like an email, but it shows up when the PMD logs into the chart. But it is an interesting research outcome. So anyway, they also troubles me, where they limited, they're like, we're going to pick which features we're going to look at statistically. And they actually said, like, other things don't make sense. Like, we don't care about your ethnicity because statistically, if you look at enough things, something's going to be positive. And we don't think ethnicity is a significant risk factor. But they didn't include what I think are potentially some important risk factors, like exertional syncope. They were using people greater than 60, so I don't mind as much that they didn't include people with weird syndromes, because you think that would have been discovered by then. But this is the list that they looked at, and this is what they meant when they said abnormal EKG. One problem immediately on this study is that like 2,500 patients refused to be part of it, which is like 70% of the amount that consented. They had very good follow-up. Not that many people withdrew. And they came up with this score, which bothers me because I don't like BNP, and it got double the points of any of these other features. And I just want to point out, they included hypotension, like history of CAD, and like all these other things didn't show up that other studies have shown are super important. So I don't know if they like didn't have enough bad outcomes, and so statistically they weren't picking these things up. This is all very new, not externally validated, but that's their list. When they look at it, it's more sensitive and specific to physician gestalt by a little bit. This is an area over the curve graph that looks at true positives and false positives and what they identified. The dotted line is gestalt, the straight line is the faint score. And then when they looked at sort of like a change in dispo and outcome, it was not statistically significant. They did show that if your score is 0, your estimated risk is 0.9% of a problem within a month, which is great. But if you have a 1, it's 3.1, which in our country seems to be too high to safely discharge someone, unless you want to do the shared decision-making path. So not ready for prime time. If someone is 0, that is good evidence that they might be able to go home, but you have to send a BNP on all your Syncope patients. You know, it's funny, we didn't talk about this, D'Souza. What do you think about a BNP for all these patients?
So probably what you're finding is patients who have undiagnosed elevated LV pressure, undiagnosed cardiomyopathy. It's the first time you're diagnosed. They don't have a history of it, but you're screening them for.
That's fair.
Systolic heart failure reduces ejection fraction, or maybe RV dysfunction as well. So anything that stretches the atrium and elevated BNP, you just may have some. I'm not telling you.
It's funny. Because the other thing is how many of these people would be picked up if you did a good history physical or a quick ultrasound?
I mean, that's the thing here. I mean, you guys you're underestimating your intelligence if you score these scores. I know it's painful to do with a busy shift, but just think about these patients a little bit, examine them properly, ask them a black belt, black bloody stool, suspect hypovolemia. You're going to pick up the 6 Syncope patients. And then look at your ECGs. And the ECGs are abnormal in ways that Grock was talking about. Then you got to worry about that. You don't necessarily have to admit. You probably don't have to admit almost any of these patients, unless it's symptom syncope, because then they have other things that are causing it. The other ones, you can actually talk to them. So, like, what do you want to do? Do you want to stay in the hospital overnight with Falcone and Obs unit? Or do you want to go home and and watch your programs, see your stories on TV? You can talk to them.
But it also will give you other information. There's been several times when these patients on ops were admitted for CHF versus COPD or things like that. We just didn't throw a probe on them and answer the question before we take them. These are things we can do.
The other thing that I think I'm a little spoiled by at the VA is they apparently give out Holter monitors like water. So I can order a Holter from the ER and it will be brought to the ER within like 20 minutes. And so that also makes me discharge a lot more folk because I give them a Holter, I send a message to their doctor, and I get them a cardiology appointment within a week. It's like, if you can do those things, most of these people do not need to be admitted if they are like elevated risk, but everything is normal on your business. This is what they say the sensitivity, specificity, and negative predictive value is, which is pretty good. So we did step 1. We did step 2. This is step 3. Figure out their dysrhythmia risk. I tried really hard to come up with a fun mnemonic and I failed. So fa-he-he for those 6 features that are automatic admits for me. And then the Canadian risk score and the faint score. So step 1 is what? Syncope verse? Seizure fall. Step 2 is, it's on there. True versus symptom. And step 3 is their dysrhythmia risk. And these are, I decided I will now only put key references because when you have 45 references and no one can read any of them, it's not that useful. But these, to me, are like the 4 really good references you should read. I will say that this one, the AHA, is like not super applicable to the ER, and it's really long. And then I also really like that guy's name for the second one. He's like the Canadian Syncope score guy. Yeah. And then in his picture on like the blog, he has this enormous smile that just makes me feel like he's a good person. All right, and those are my chitlins. Yeah, man. 4 and 2. He's nice. She's feisty.